moderation, in concert with an effective exercise program, dietary regulation, to get the patient in some sort of exercise rhythm, really abates and diminishes their propensity to develop complications of diabetes. So here's foods to avoid. And of course the last one's my problem because I like food for the gods. I know I'm leaving back to Miami on Sunday, but I'm stopping in Goldilocks to get food for the gods. That's great, great stuff. Okay, so now let's talk about some wound etiologies. Diabetic neuropathic wounds. These are craters in the bottom of the feet. Why would a patient develop a neuropathic wound? Here's the pathophysiology. Most patients who have diabetes will develop peripheral neuropathy. Diabetes is a very bad metabolic problem for this instance. Too much glucose comes into the body, and in order to get the glucose, which is a source of energy in the cell, you need to have the key to the lock. The key to the lock is insulin. Insulin opens up the key, the door to the cell, allows glucose to come in. Metabolization. If insulin is not available and you have that resistance for the glucose to get in, it goes into the nerve cells, the myelin sheath. It swells the nerve. After some time, it diminishes. When the glucose comes out of the nerve, what happens? The nerve scars. So the electrical transmission that goes from node of Ranvier down to node of Ranvier via the myelin is ineffective. That's why the patients develop peripheral neuropathy. That's why they cannot feel a little speck of sand in their shoe. So what do they develop? Here's what they develop: a neuropathic lesion. These are very difficult to treat if you don't use collagen. Very difficult. But when you use collagen, you're introducing a surrogate composition of collagen type 1 bovine origin into that wound, and the wound starts to granulate, even in the most extreme conditions when you have a problem with hemodynamics. You can treat these wounds effectively. Venous stasis. 90% of venous stasis wounds are chronic. Pathology is we have a deficient venous valvular system. Gravity is not a very nice friend. It pulls blood. It allows the valves to become incompetent. And when you have incompetent valve, you have a lot of venous pooling circulation in the dependent part. Venous stasis wounds are most commonly seen in the medial aspect of the lower extremity, and they're painful. They're painful. Arterial insufficiency. Arterial insufficiency, also known as ischemic ulcers, occur on the lateral aspect of the lower extremity. And what is a common pathophysiology or causative cause for arterial insufficiency? Any of the young doctors? Smoking is one, right? That's true, but also the contributory effects of diabetes that form microangiopathic deficits. So diabetic microangiopathy is your main cause for arterial insufficiency ulcer. These ulcers are extremely painful, more painful than venous. Skin tears. Skin tears are commonly seen in the elderly because of friable tissue. They have decreased nutritional status. What happens here? We have patients who have skin flaps or non-skin flaps. Putting collagen on these wounds turns the tide from non-healing, protracted, recalcitrant wounds to a wound that produces granulation tissue. Getting that integumentary system back to a form of patency. Very important strategy and goal in medicine, in wound medicine. Pressure ulcers. Stages 1, 2, 3, and 4. This is a coccygeal ulcer where you'll have exposed bone. And even though you have exposed bone, you put collagen in a wound like this, you will granulate. Remember the fibroblasts, remember the angiogenesis, the growth factor release, all the other constituents, the submolecular mechanisms that are activated? You will definitely heal a wound like this, even if it looks as grave as this does, where you have exposed coccygeal bone. In the hip, a trochanteric lesion, you can heal it, not a problem. It's a capacious wound. It has a deep capacity to it, but once you put the right amount of collagen there, you start to grow tissue. It becomes activated. It becomes live. And it will fill that wound in with excellent tissue, and the patient can have a restoration of their quality of life. And then we go to surgical wounds. This is a wound that has dehisced because of mechanical changes. And you can take collagen, putting it on the line of closure, making sure that those suture lines, or staples if you choose to use staples, don't reopen. Collagen is going to induce the fibroblasts to produce the tissue that we need to have in these wound conditions. First and second degree burns. Collagen is very effective here. Here's a first degree burn. They are moist. They include the epidermis, and they're painful. So putting collagen on a burn and a painful wound like venous stasis or arterial insufficiency, here's what you do. Not only do you granulate, but you mitigate pain. And you mitigate pain because the collagen covers the free nerve endings, forming an occlusive dressing. When you have an occlusive dressing, the patient after 24 hours says, wow, I feel better. I don't have this pain anymore. And here's a third awesome benefit to using collagen. You minimize the potential for scarring. Pretty cool. Pretty cool for the aesthetic surgeons and the plastic surgeons who are doing dermatologic procedures or aesthetic procedures, and they don't want to have the patient produce a scar. Second degree burn. This is a dermal involvement, a moist wound. And if it's superficial, it takes off the papillary layer. And if it's a deep secondary, it takes out the reticular layer. So we have another layer that's being invaded here. We have another layer that's being assaulted and insulted. Putting collagen on these wounds decreases the pain quotient, granulates, and reduces the scar potentiality. This is a case I consulted on in South Africa. Very, very sad case. This is an acid burn. And you see that you have an erosion of the septum, erosion of the turbinates, and unfortunately this patient lost her her right eye, but here's what collagen did. We regranulated this tissue. I wish I had a post photo. But just to show you, from a simple wound condition such as a skin tear to the most grave, which would be an acid burn of this magnitude, you can granulate and restore some quality of life to this patient and prevent any other sequelae or comorbidities from developing. That's very important. That's what we need to remember. So special wounds such as this, collagen is extremely effective. Now, there are several definitions of collagen on the market. There's a lot of collagen products. I like modified, and the reason why I like modified is because it is immediately available for the body to use. It doesn't have to be broken down via the enzyme of collagenase. Every other collagen product on the market is in the native intact state. You remember the triple helix slide I showed you with the tightly coiled braid? That's the native intact. It takes the body about 10 to 14 days via collagenase to break it down. When you put modified collagen in a wound, it's ready to go, non-stop. It's like taking a non-stop flight from Miami to LA. If you use native collagen, you have to go from Miami to Chicago to Houston to LA. So why not put modified derecho now? You have no diversion. And that's the effectivity. You start to